Good day and welcome to the Association of State and Territorial Health Officials Media Deskside Briefing. State health officials address COVID-19 vaccine distribution, delivery, and equity concerns. Today's conference is on the record and is being recorded. At this time, I would like to turn the conference over to Mr. Mike Fraser, Chief Executive Officer. Please go ahead, sir.
Great. Thanks so much, operator, and thanks everybody for joining us today. We're really pleased to have this opportunity to have you hear from two state health officers, two wonderful leaders, part of our ASTHO membership. This call is on the record, and we're pleased again to provide any follow-up post-call, but we will be taking questions after some brief presentations. I'm Mike Fraser. I'm the Chief Executive Officer of ASTHO, the Association of State and Territorial Health Officials. And joining us today are Dr. Nirav Shah, who's our ASTHO President and Director of the Maine Centers for Disease Control and Prevention. He's previously served as the State Health Officer in Illinois as well, in addition to numerous other public health experience. He's received both his medical and law degrees from the University of Chicago. And also joining us is Dr. Thomas Dobbs, who's the State Health Officer of the Mississippi State Department of Health. He's been in that role as State Health Officer since 2018, but prior to that served in the department many years as a District Health Officer and State Epidemiologist. He holds a medical degree and a Master's of Public Health from the University of Alabama at Birmingham. We're really pleased to have both of these experts joining us to share some field experience for the reporting on COVID vaccine and other items you all may want to discuss. Before we hear from Drs. Shah and Dobbs, I did want to share some remarks and just set some context for you all. Vaccine rollout continues to be a major focus of coverage on COVID response, and we want to update you on what we're hearing from two states, but also from members across the country. About just 4 weeks ago, if you go back, it feels like an eon, but just 4 weeks ago, we had the initial vaccine rollout over the holidays, and we held a briefing 4 weeks ago indicating that things were slow to start, but we anticipated things would speed up and become more efficient. And I'm pleased to say from our vantage point, the vaccine effort has sped up and has become much better. Several state health officials testified this week on vaccine rollout in Washington at a hearing by Energy and Commerce Committee. And unfortunately, there continues to be pretty significant misunderstanding of what states are doing and some pretty partisan interpretations of various pieces of this program, especially blaming states for either hoarding vaccine or not using their entire allocation, or even suggesting that state plans don't work. One member of Congress went so far as to suggest that states should just be grateful for the vaccine that they do have and stop asking for more, and that's particularly unfortunate. We're here today to really share that it's our perception that state plans are working, and states are iterating and evolving their programs with the field reality of being public health practitioners. And the system itself is working. A major consideration that has not been well described is the lack of vaccine, the vaccine supply. And there's no effort of planning that can really speed up vaccine supply. So, of course, there's going to be problems in rollout, and there's going to be tech systems that need to be stood up. But overall, what's really constraining our ability to vaccinate more folks in the country is not lack of sites or lack of plans, but rather lack of vaccine itself. So as of Tuesday, we learned that the administration is making 10.5 million doses available per week to states. That's 10.5 million doses, first and second, based on current supply. And at this rate of supply, it will take some time to reach all Americans. Despite what the administration has ordered for the future, manufacturers still have limited ability in terms of creating supply. That 10.5 million is an increase from when we initially rolled out at about 8.6 million doses going to states. The administration also announced, and we're encouraged by this, that it's committed to providing a 3-week outlook on vaccine allocation to help stabilize planning and make planning more predictable. So while that's going to be super helpful, and we'll hear why from our health officials. It's really important, though, to realize that until production increases or new products are approved, we are looking at only 0.5 million doses a week going to states to be allocated. And we do hear from states that they could vaccinate 2 to 3 times more people if they had the vaccine. Second, I just want to address, and I know we'll hear from our health officials on this as well, this constant attention to the number and the difference between vaccines being allocated, distributed, and administered, and this perception that there are states not administering all the vaccine they're allocated. As of today, 56 million doses have been distributed and 34 million have been reported administered. And that's a national average of about 61%. And there's a lot of criticism around this number. A number of factors, all of which were predictable and understandable, are contributing to this difference, but it's not a simple answer. We know that there was a learning curve, so that created some delay in administration. People had to learn how to deal with this vaccine and administer it. We know that there is a dose administration reporting lag time, though we do understand from talking with CDC that actually that's not a major factor here. We do know that there's under-reporting of administration by some providers. States are beginning to understand that better and why. We know that there's manual reporting of administration that's often batched and done at a point of time in a week, so there's delay. And we also know in smaller clinics or in clinics where the electronic health record is not linked to the state immunization information system, there can be delays and even missed reporting. We also know that the vaccine inventory has an impact on administration and the difference between distribution and administration, and that it takes time once the state receives the vaccine and it's counted as distributed to actually get to a clinical setting where it can be administered. We do know that there are some sites that have some conservative inventory management, and they are holding back vaccine to assure they have enough supply for second doses. And we're beginning to address that, and we'll hear from our health officials on that. We also know that they're low throughput sites. There are sites that don't see huge volume. They're not mass vac sites, and they will hold on to their doses and administer them slowly. And we know that a significant issue has been the uptake and over-allocation to the Federal Pharmacy Partnership for Long-Term Care Facilities, a program that had allocated based on beds, not census, for example, and states are taking vaccine. So we just want to share that we're working with states and CDC to better understand this difference. And again, we'll hear more about this from Dr. Shah and Dr. Dobbs. So without any further ado, I'll turn it over first to Dr. Nirav Shah, our ASTHO President and Director of the Maine Center for Disease Control. Dr. Shah?
Great. Good afternoon, everyone. Thank you, Mike. Again, I'm Nirav Shah, the Director of the State of Maine CDC. Honored to be able to join everyone today and discuss vaccine administration from the state perspective. Let me start out by just setting the table a little bit and then picking up on some of the points that Mike made. First, number one, I want everyone to know that states are working 24/7 right now to move shots into the hands of providers who can get them into arms as quickly as possible. That is, and I speak for my colleagues across the 50 states and the jurisdictions and territories, that is what we are working on night and day right now. The prime directive underlying all of that is to ensure that not a single dose goes to waste, that every dose is allocated and used as efficiently as possible. And as Mike noted, I think it's really important and critical to recognize that there are still not enough doses to go around. We are very thankful for the recent increases in supply that are coming into states. And as Mike noted, we are also very thankful around the stability surrounding the projected allocations that are coming into states over the next few weeks, rather than just having the insight over the next few days. This is a real asset when it comes to planning. In percentage terms, the increases that we've seen over the past 2 weeks are impressive and welcome. 16% for the week before last, 5% for the week that's coming up. Those are very, very welcome, and we are thankful for them. But it's also important to note for context what those translate into in numerical terms. Again, a 20% increase over the last 2 weeks is fantastic. But in our state, in Maine, that translated into about 3,900 new doses in a state of 1.35 million people. So again, while these increases are welcome, we still have a long way to go before we are achieving significant weekly vaccination allocation to really vaccinate a substantial proportion of the population. At the state level, we are increasing our throughput every single day. Indeed, I've looked at our data for the last 7 days up until today versus the preceding 7 days versus the preceding 7 days before that. We have increased our daily administration throughput in each of those periods and are laying plans to continue to do that. At this point, however, supply is what governs speed. The more supply we have, the more vaccines we can get into arms. Now, I know that seems like a discordant thing to say that there are not enough doses to go around when, at least according to some data sets, it appears as if there are doses that are being unused. So I'd like to take the balance of my time to walk through how you can reconcile or how to square those two things from a data management perspective. The first thing I would look at is when you're looking at data sets surrounding vaccines and vaccination administration, it's really important to look at first versus second doses and to make sure that you're not comparing apples to tires. First doses are what we really focus on here. Some data sets conflate first and second doses, and as a result of that, give an overimpression of what is being allocated to states. When my team and I are doing planning, we really zero in on first doses. Second doses are, in effect, a function of accounting. CDC, the US CDC, gives states a voucher for second doses. Those are doses that are not on our shelves right now. They are probably not even produced at this point. All we get when it comes to second doses is what amounts to a promissory note, a note that says, in the appropriate time frame, a few weeks in the future, when your state needs these second doses, you can give us back this promissory note and we'll give you doses. But in some accounting sets, in some data sets, those second doses already appear on our ledger, even though they may not have even been produced, let alone distributed to states yet. So it's just really critically important to disaggregate first versus second doses. The second thing is to discuss the impact of the long-term care facility program. It's really important to note that the US CDC and the commercial pharmacies required states to bank a significant number of the doses attributed to and used by the long-term care facility program very, very early on. All those doses were banked in the first 3 weeks. We were required to account for those in the first 3 weeks for a program that was initially only slated to go for 6 weeks, but now has slipped into many, many more weeks. But those doses are already viewed as having been allocated to states, even though right now they have not been used by retail and commercial pharmacies. What I will tell you is that in my state in Maine, we are not sitting around waiting for those doses to just get used on the timetable that retail pharmacies tell us. Indeed, we are starting to withdraw those doses from the warehouses and move them into general circulation, either using independent pharmacies in our states or in some instances, just giving them to hospitals and other sites. But as a result of that over-allocation, that over-commitment to the program in the early weeks, states appear to have more doses within their possession than they in fact do. The third thing is, as Mike referenced as well, there have been some reporting issues in states at some level. There have been reports of facilities, large hospitals, not reporting doses that are administered to state health departments in a timely fashion. In some states, we've heard reports from our members of confusion around that reporting process. In one instance, a large institution, a large hospital, was merely logging the doses in their EMR system, thinking they would be automatically reported to the state, when in fact they didn't realize there would need to be a separate and parallel process to do so. The doses have been administered, they just haven't shown up on the tally yet. The next thing to note is that there can be a lag in reporting between administration and when the doses get reported, but as we've discussed with the US CDC, this doesn't seem to account for much. The next thing to note is there is the possibility of a day of week effect. doses are delivered on Monday, Tuesdays, and Wednesdays to states, but depending on when you take a look at the snapshot of what's happening in a state, you may see a higher than average number of doses that are on hand. In many instances, it could be that they are just being delivered and not actually unwrapped and being used. So it's just important to take account for the day of week effect. Finally, the last factor that's at play here for everyone's consideration is good and proper inventory management. Especially for larger sites, they need to carry over some degree of inventory between Sunday and Monday morning to make sure that they can fulfill the commitments that they have for vaccination clinics that are scheduled for Monday, Tuesday, and Wednesday. If they don't carry over that inventory, if they were to use up every single dose on Sunday night and have a delay in getting vaccines into their hands on Monday morning, they would have to cancel appointments. Canceling an appointment or set of appointments en masse because you used up all your doses and not having anything for the folks you've committed to on Monday morning, it's not a good thing from a trust perspective. So as a result of that, this need to have some degree of carried over inventory, it can create the impression that there are doses sitting around unused, when in fact they are simply slated for use in the subsequent 24 or 48 hours. That's not a bad thing. That's just good inventory management. And then finally, and then I will stop. It's important to note that although velocity remains a goal of all the states and territories, equity is just as important of a goal. Many of these states, including my state in Maine, we have made deliberate attempts to allocate doses to places that we know will not have the same velocity of throughput as a large-scale mass vaccination site. And that's okay, because those sites where we've made deliberate choices to allocate to serve a rural or disadvantaged population. Maybe they can't do 500 shots a day. Maybe they can only do 20 shots a day. But that's important for the community members in those places because they may not be able to drive a couple of hours in snowy conditions to get to a large throughput facility. To put a finer point on that, it's important to ask how quickly we are using doses, but we also have to ask upon whom are we vaccinating. So not just how quickly are we vaccinating, but who are we vaccinating and making sure we are achieving equity there. So with that, I'll turn things over to my colleague from Mississippi, Dr. Dobbs.
Hey, thanks for everybody being here, and certainly we're super excited about this phase of the pandemic response. If we look at our experience in Mississippi, similarly, we were off to what was perceived to be a slow start because the vast majority of our vaccine allocation was committed upfront to the long-term care partnership. And in the going to the end of the year, we were ranked last in the country in the rate. But once we turned on our high throughput drive-through centers, and we have 21 high throughput drive-through centers in the state of Mississippi, over the last several weeks, we've moved up toward the middle of the pack, which is fantastic. We want to focus on that speed of delivery process. But we do need to continue to remember the disparity issue. And in Mississippi, African Americans make up about 37% of the population, but only account for about 19% of the vaccine. So that's an enormous issue. When we look at this problem, we have identified two big areas that others have identified as well. Clearly, one of them is trust. And having faith leaders, African American leaders in the community step up, get vaccinated, speak about the importance, help educate the community has done great. And now we find ourselves in the access issue. We find that barriers exist similar to our pre-existing disparity barriers that have been around for decades. And they're not going to be any different for coronavirus vaccination than they are for access to healthcare for any other reason. And within these barriers, we know that things that make a high throughput drive-through work very efficiently. We have an online portal for getting appointments that's very easy, it's inefficient, but maybe that's not the best way for everyone. We also have a call center, but sometimes it takes a while to get through, and we know that can be a barrier. So when we look at locations where we can get the biggest bang for our buck for disparity communities, it's important to identify those partners in the community or those geographical areas that can help you get to the populations that you are lagging behind in. As an example, if we look at our partners within the community health center world or the federally qualified health centers, we identified them as key partners in the fight to fight disparities. So within community health centers, about 71% of their vaccine goes to African Americans. When we look at our dialysis units that we're supplying, 72%. But when we go back and look at our drive-through clinics, we see that 18% of the vaccine is going to African Americans within the drive-throughs. That's a huge gap. It's a huge gap not only compared to the places where we see success, but also when we consider the amount of resources that we are devoting to the drive-through centers. Now, they're very important, and they have helped us now reach a large proportion of Mississippians. In Mississippi, almost 40% of people over 75 have received at least one dose, and almost 30% of everybody over 65 has received one dose. Those numbers are going to really pay major dividends going into the future, not only in mortality, but in hospitalization. But if we don't also have a parallel focus on addressing health disparities, we won't really get to the health gains that we're hoping to make. And then the other thing is we are very excited to look at data systems. Having solid, dependable public health infrastructure is something that we have neglected for decades. So we've gone into this pandemic without the integrated, interoperable health records and health systems so that we can do these things efficiently. Talking with Dr. Shah said about the hospital, not understanding that there's a separate sort of data process. We've seen that over and over again. In the state of Mississippi, the vast majority of vaccine entries that must go into the registry are done by hand. And you can imagine the efficiencies, the loss of efficiency you're seeing by having to do that. So having this investment, this federal investment in state public health, and the ability of health systems and the public health system to intercommunicate efficiently and accurately is going to be an enormous benefit, not only as we respond to the coronavirus pandemic, but also as we look to future health challenges and pandemics that we're almost certainly going to have in the future. And that's all I have. And thanks to ASTHO for being fantastic leaders with the COVID response.
Thank you, Dr. Dobbs and Dr. Shah. Thank you as well. We'll now take questions from our participants. Operator, if you could remind folks how to queue and just start, that would be fantastic.
Absolutely, sir. If you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open, so please state your name and outlet before posing your question. Again, folks, that is *1 to ask a question, and we will now take our first. Please go ahead.
Hi, thanks for doing this. This is Jessie Hellman, a healthcare reporter with The Hill. I know this was touched on briefly, but if I was just looking for a little more information. The CDC says nationwide that the racial and ethnicity data of people getting vaccinated is missing in about 50% of vaccinations. Is your state collecting this data? And if so, how complete is it? Are providers in your state required to collect it? And what are some of the reasons behind why this data appears to be missing in a lot of cases, considering that we don't seem to be seeing the same gaps in data for like ages and sex of patients and other identifying information. Thank you.
Sure. I can go ahead. Oh, go ahead.
Go ahead.
No, I can go ahead and dive in. Thank you for that question. That has been something that, at least in our state of Maine, and I know our colleagues across other states have looked into. Then this is Nirav Shah. There are two interrelated things that are going on, at least based on the analysis that we've done in our state. One is that some individuals are reluctant or hesitant to disclose or provide their racial or ethnic background as either part of the registration process beforehand or even when they show up on site. As one individual indicated to me, as one provider indicated to me, a patient said to them, why do I need to tell you what my background is just to get a COVID vaccine? So the bottom line there is that we need to do more education to individuals around why we are asking for their racial or ethnic background. The second issue that we've spotlighted is that although we do ask, if not require, providers to collect that information, some may not be doing so regularly or systematically. That too points to the need for more education from us to providers to inform them around why it's important that they ask those whom they are vaccinating for their racial and ethnic background. I think the bottom line there is that we need to do a better job making the case for why collecting that information is important from an equity perspective, and outlining what we do intend to use those data for and what we don't intend to use those data for.
Thanks, Dr. Shah. Dr. Dobbs, any more to add on that?
Yeah, no, so this has been something that we've been watching from the beginning. We fortunately do have parallel mechanisms for analysis so that we can validate information. Sometimes having parallel systems is a burden, but in this way it's very useful. What we have identified is most of our lack of data, about 13% do not have race data attached, and mostly it's a mapping issue when the electronic health records are communicating with our registry. It's something we're working actively on. The rest of the data we feel very strong about that it is accurate. And when we look at the people coming to the drive-thrus, we have, and that's about 3/4 of our vaccine allocation. We do see very clearly that we are getting good data, and it's pretty spot on. Only about 18% of the vaccines going to African American folks through the drive-thrus. There are some that we've identified that are reluctant to put their race data down, but the vast majority in Mississippi is not that issue, but it's basically an interconnectivity issue between electronic health records and the data registry.
Great, thanks. Any follow-up on that?
Yeah, I was wondering, would it be helpful to get more guidance or assistance from the CDC on this? Is there anything that the federal government could do?
You know, I think among other things, what would be helpful is just as part of the overall national messaging, making the case for why data are important here, not necessarily just racial and ethnic data, but data collection of all sorts. What separates the current COVID mass vaccination plans and protocols from previous ones, some that were done as recently as 10 years ago, is the laser sharp focus on equity. And without the proper data, it's really difficult to know whether we are doing a good job on any metric, particularly those around equity. So larger scale discussions and messaging from the federal government and the CDC around the importance of collecting data of this nature for equity reasons, that would be helpful from a state perspective.
And my only thing I would add is long-term investment. We do this over and over again. We have a crisis and we respond and we say, how do we fix it? But we don't prepare for the next one. These are things that are easily addressed with investment ahead of time. And that's what we need to do. We don't need to lose momentum here. We need to make sure that we build our public health data infrastructure in such a way that we can use it for future challenges. I think CDC's done a great job in beefing up their internal data structure around immunizations, but this needs to happen in all states and all territories in the United States.
Thank you.
Great, thank you. Operator, why don't we go to the next question?
Once again, if you would like to ask a question, please press *1. If you find your question has been answered, you may remove yourself from the queue by pressing *2. We will take our next question. Please go ahead.
Hi, this is Emily Kopp with CQ Roll Call. I was hoping Dr. Shah could elaborate on what he meant about second doses essentially being a promissory note. Is that part of the disparity that we're seeing between vaccines administered and vaccines distributed?
It may be. I don't want to say uniformly so. I will. Let me rewind. Promissory note or voucher, whichever metaphor resonates with you more. But what is happening is that when we get notified of an allocation, what we really focus on are the first doses. We also separately learn about what our second dose allocation will be. But when we find out, say on a Tuesday afternoon, what our allocations will be for the subsequent week, now subsequent weeks, we are assuming, and it has been true to date, that there will be second doses to accompany those first doses at the requisite time, 21 days for Pfizer, 28 days for Moderna. In some instances, on some data sets, those second doses appear. So if we find out we're getting, I'm going to make up a number, 5,000 new doses next week, in some data sets, those second doses are already on the ledger book. So it appears as if 10,000 doses are coming, when in fact those latter half are not actually showing up for a few weeks. And that can, of course, overinflate the view of what is actually in the state, and by twofold. So what I meant when I indicated it's a voucher is each first dose essentially comes with a voucher for a second dose that will come off the production line at the appointed time. And thus far, that has held true throughout the first weeks. I guess my recommendation, or what I had seen in some instances, is data sets or trackers or reporting that did not disaggregate first doses versus second doses. When I talk and when my team and I plan, we really zero in on what the new first dose numbers are, with the expectation that the second doses will be coming at the appropriate and appointed time.
Great, thanks.
So I know you addressed.
Anything to follow?
Sorry, I was just going to ask, you said you were getting maybe like 4,000 more new doses. How many of those are first doses?
Those are all first doses. Those are new first doses. Okay. Yep.
Got it. Thank you.
3,900 over the last 2 weeks. Thank you.
And we will take our next question. Please go ahead.
Hi, I have a question about the ways that people are able to find doses. Sorry, this is Selena from NPR, Selena Simmons-Duffin. There are like in many states, there's a very confusing patchwork of sign-up systems depending on whether you're trying to get your dose through a hospital system or whether you're using your local health department or, it seems like a really challenging thing for a person who might be eligible to find out where there's vaccine nearby, where there are appointments, and how to get those appointments. So my question is, what's your understanding of the challenge where you are, and how are you trying to address it? And then as a follow to that, is there on the horizon any prospect of something coming along that would make this more straightforward for consumers so that it was clear where to go and it was clear how to get an appointment and whose turn it was?
Dr. Dobbs, I'll let you start us off there if you want.
Yeah, so it is a huge challenge, and I can tell you where the successes are and the challenges. So about 3/4 of our vaccine supply we use through high throughput drive-throughs, and that part's pretty easy. We have a call center that's dedicated to taking those appointments, and we also have an online portal it's pretty simple and direct and easy to use. But obviously everyone can't have that. But so for that amount of vaccine, it actually works out pretty well. There's just not enough vaccine. I mean, when we put in 30,000 doses for first appointments yesterday, and they were gone within 4 hours. So there's amazing demand out there. The part that's really a challenge is our partner locations. The remainder of the doses we do share with clinics, hospitals, community health centers, and other locations. And we actually do publish once a week what locations receive new vaccine. The challenge is how do you access from these different locations? Because every clinic, every hospital has its own mechanism of communicating, recruiting, and setting up appointments. That's the real challenge because we have, basically 100 different ways to do the same thing. We're working on that. We are going to have an interactive website to see, where you can go and what number you call. But those sorts of unknowns where you don't have sort of unity of control, it's going to be an ongoing challenge, and we'll continue to try to find ways to address it.
Yeah, Selena, this is Nirav. I concur with everything Dr. Dobbs said. Let me answer start out with the last part of your question, which is there anything in the offing around a nationalized unified platform? And the answer is that there was supposed to be. There were great plans to have a unified nationwide sign-up, registration, location identification platform called VAMS, V-A-M-S. That platform does exist. I believe that there are a small handful of states that are currently using it. I know from communications with at least one of the state health directors that is currently using VAMS that they are looking to abandon it very quickly to move to something else because it really hasn't lived up to its promises. Appointments get canceled. The ability to schedule with flexibility has not been there. So one can hope that there will be a successor in the future. In the meantime, I know that many states are going it alone, as is our state in Maine. Right now, I concur with what Dr. Dobbs said. Right now, there have been the larger hospital systems that have set up their platforms in which to register, but that doesn't necessarily encompass everybody. That was the promise of VAM that has not really come to fruition. So what we are doing in our state is using a third-party solution and coupling it with a call-in center so folks can register for vaccines in any of many different ways. They can go on the website, they can call, they can register their friends, their parents, their spouses, things of that nature. But unfortunately, for now, it has been, I agree, it has been suboptimal thus far.
You follow up on that?
Oh, I'm just surprised. I've never heard of that system. That's an interesting background. I have heard about Vaccine Finder, the tool that CDC is working on launching, but it doesn't seem to solve the how do I get an appointment near me problem. That seems like it might be a patchwork forever.
Well, I don't know if it will be. At some point with IT solutions, there is a bit of a lock-in effect, and the cost of switching from one registration platform to another can be significant. So we in Maine, we declined to use VAMS after vetting it in January, spending a lot of time looking at it and kicking the tires. We found that it had several limitations, and so we did not activate it at all. And again, I've spoken with at least one counterpart of mine where their state did activate it, and they can't wait to find another solution.
I think we're going to see a patchwork. As more sites come online, like health centers, like pharmacies, there's going to be a need to think about this. But again, there is no national plan for that yet. So states are doing it state by state.
Hey, Samina, you don't have to take it from me. There was a really nice piece in the MIT Technology Review a couple of days ago that dove deep into VAMS.
I'll look for it. Thank you very much.
Great. Next question.
And we will take our next. Please go ahead.
Yes, hi. It's Alicia Alt with Medscape Medical News. And I'm just wondering, given that, for instance, Maine and Mississippi have large swaths of rural areas, has there been any thought given to bringing primary care physicians, family medicine physicians into the mix as vaccinators? Or are the logistics, given the two vaccines we have now, just too difficult to think about using them?
Hey, this is Thomas. We do that. That's actually one of our key strategies to getting into rural areas where we have rural health clinics, community health centers, or private clinics where we know we have difficulty with access to vaccines. That's not a problem. We have hundreds and hundreds of clinics that are registered to be providers. The two challenges that we have are amount of vaccine. Seriously, dozens of calls every day, if not hundreds, of people saying, hey, we need more vaccine, we want vaccine. I mean, having more vaccine would solve a lot of our challenges. But the other part is this centralized information about how do you make an appointment. It makes it that much more difficult, but the vaccines are getting used up. It's just people are finding it, but it can be a challenge.
And I'll add, I'll concur with Dr. Dobbs. We too are using some rural providers, namely and principally F2HCs, as part of our efforts to make sure that there's coverage in rural areas. Generally speaking, let me say one other thing. For weeks now, I think this is now the third week, every single recipient of vaccine that we have given to in Maine has been unhappy, by which I mean they have all reported they could absolutely use more than what we are giving to them. We give them 100, they say they can do 500. We give them 500, they say they can do 1,000 now. So systematically across the state, large providers, small providers are able to do more, hence underscoring the need for more vaccine to satisfy the demand that we know is out there. Second thing is when we look to give vaccine to sites, there are a couple of criteria that we are looking for, one of which is just the storage capacity. Can they store the vaccine in the temperature control that's needed? The second is can they vaccinate folks safely, meaning do they have a large enough waiting room through which observation can occur without having to engage in close physical contact or distance? Can they make sure that at the end of the day, there's not a single dose wasted? So on and so forth. There's a number of criteria, and we found that for very small practices, solo practitioners, those things can be challenging. We have also heard concerns that for solo practitioners, for them to become vaccination sites may crowd out other primary care services that they may be providing. So for that reason, our rural strategy is focused on FQHCs. But eventually, once supply is no longer a constraint, we hope to be able to blanket every corner of the state, every provider who wants vaccine to be able to administer it.
Okay, thank you.
Great, thanks. Operator, we'll move to the next question.
Please go ahead.
Hi, it's Elizabeth Weiss with USA Today. Thanks for taking my call. I actually have two questions, and the first is the Pfizer and Moderna both say that they are producing the same amounts of vaccine every week. So a question is, why do states seem to be getting fluctuating amounts? Do you have any insight into that? And the second question is, both HHS and the Ad Council had said they would launch national vaccine information communication programs in January, and that hasn't happened. Is there a need for communication? Are you hearing that anything is coming at the national level? And if states are doing it on their own, are you guys sharing resources? And that's it. Thank you.
I can start there. As to the former question around the supply coming into states, what I will say is, as to the Pfizer amounts that have been coming in, our supplies of Pfizer have been remarkably stable since the week of January 4th. I'm just looking at my allocation spreadsheet here, and since January 4th, we have received largely the same amount of Pfizer. And similarly, our rates of Moderna were relatively steady up until just the week of February 1st, this current week, when they did go up. I don't have a sense of where that excess came from, whether it was a function of increased production or other changes in allocation. I'm not sure about that. Again, our bottom line is get us the doses and we'll get them into arms. So we're thankful for the increases, though I don't have more insight into from where they may have come. As for the advertising campaign, we too have heard that there are campaigns in the works at the national level from the Ad Council. I'm not sure what the status of those is. I will say that we're encouraged by a national campaign. We think there's value in it. Even though we have seen very high demand for vaccine, we don't want that demand to tail off. Let me just end by saying one of the refrains over the past 6 months has been about every other week there's a national survey indicating the percentage of folks who are willing or reticent to take vaccine. And those numbers have fluctuated quite a bit over the last 6 months. I think there are, in some quarters, those who look at those numbers and say, oh my, what's happening? What I will say is that the fluctuations in those numbers, although there are sociological questions about why that is, that's an opportunity. That means with proper messaging and messaging that focuses on vaccinating with confidence, we can look at those fluctuations as an opportunity to solidify the confidence that we have in the vaccine. So it just, again, speaks to the need to have a unified, consistent campaign.
Yeah, this is Thomas. I have nothing to add to the first point. Thank you, Dr. Shah. On the second, we're looking forward to having a national campaign. We do have our own local campaign where we realize how important it is to reach those who have maybe have some underlying reticence. We do have a statewide sort of hesitancy survey that we're going to be analyzing this week that'll help us understand going forward. But yeah, no, it's going to be huge once we start having vaccinated everybody who is on the more eager end of the spectrum.
Anything else, Ellen?
No, that'll do it. Thanks.
Okay, great. Next question.
We will take our next question. Please go ahead.
Oh, hi, thank you. This is Stephanie Epps from ABC News. I have two questions, but I'll just start with one. We've heard some state officials and conversation about whether states are holding back second doses, and my impression has been that that is a concern that, separate from the doses that the federal government is basically promising for that second dose, that the shipments are partially being held back out of concern that those second doses won't come. Is that something that you're actually hearing is happening in a lot of states? And, you know, do you have an explanation or about why they might be doing that?
Dr. Dobbs, you want to start?
I think that is happening. I mean, I'll just say that it's something that we're struggling with right now because the allocations come in first and second dose distributions. And if it's labeled as a second dose, especially for our partners who we can't guarantee they're going to get more first doses to sort of counterbalance that, it's a real inventory management issue. We're now struggling with what was our initial sort of guidance that first doses were first doses and second doses were second doses. And when they come well ahead of time, we find ourselves with second dose inventory. So I do think that that's a real challenge that we're going to have to struggle with.
On our side in Maine, I've given a clear directive to hospitals and other recipients not to hold back second doses, by which I mean the following. If we send somebody 100 doses of Moderna, there have been reports, as Dr. Dobbs noted, of some recipients of those vaccines saying, you know, I don't want to bank on the fact that this promissory note that Nirav says that he's got with the CDC is going to come true, and so we're just going to hold back 50 of those doses for 28 days. I've told recipients of vaccine in Maine with whom we have provider agreements, that doesn't work for me. If I ship you 100 doses of Moderna, I want to see those into arms as quickly as possible. Let me worry about getting you the second doses at the appointed time. Do not keep them on the shelves.
Thanks. Did you want to add your second question?
Oh, sorry, I had to unmute. And my second question was just broadly, you know, as you're looking forward to the next few months, what are your concerns about, you know, the next phase of this, and what do you still need in terms of support to keep this distribution happening on pace and equitably?
Okay, well, I'll go ahead and tick off a couple of things. Number one and number two and number three are vaccines. We need more vaccines, we need more vaccines, and we need more vaccines. After that, we probably also need assistance, or we're recruiting internally within the state for additional folks to serve as vaccinators. We're working with schools of nursing, schools of allied health of all different sorts to be able to have a cadre of vaccinators who can be deployed to various and different parts of the state to provide vaccination. So that would be my number two. Or number four, sorry, the first three, again, being vaccine. And then number five would be a really good IT system that encompasses both data, registration, validation, as well as insurance and billing. A unified platform for all of those things. If it were a national solution, great. If not, we're going to have to focus on making one up here in Maine. But those are the things that we are looking at on the horizon.
Yeah, I agree entirely. I mean, we are only tapping into about probably a third of our vaccination capacity, if that much. If we got more vaccine, we could vaccinate 2 or 3 times more people easily. based on what we're doing and what our partners are able to do. That's the biggest one by far. IT infrastructure is another huge one, but it's down the list on the vaccine. I mean, we can make do with our existing IT infrastructure, but this is really more of a long-term play. It's not going to fix it for next month. It needs to fix it for the next decade.
And this is Mike. I think, the only other thing I would add for the future is, depending on the vaccine products that are introduced, if there's a new vaccine with significantly different efficacy, for example, how that's distributed into whom is going to be a big problem that needs to be sorted out. So yes, that's, again, something that we're thinking about for the future as well. Great. Next question.
Please go ahead.
Hi, this is Marisa Fernandez with Axios. Thanks for doing this call. You both briefly mentioned that it seems like the most common way for people to sign up for a vaccine appointment is through their state online. There's been several reports circulating on kind of the frustration among senior citizens who are not as internet or technology literate. Are there any specific plans you can share with us that you've seen between your states and the federal government to kind of help fix this inequity, if any?
Go ahead, Thomas, please.
Yeah, no, thanks. We have identified that as a challenge early on as well, especially now that we've expanded it to other age groups where you have more tech-savvy people competing for the same slots. That's a real challenge. We do have a call center that is able to help. We're actually setting up a separate call line for 75 and older so that there's no competition even for those individuals. So we'll continue to try to lower barriers. The other thing is we've seen other community groups who have volunteered to enter appointments for seniors, and that's perfectly fine.
I applaud Dr. Dobbs. Those are both really great and creative ideas. We're thinking along the same lines here. By average age, Maine ranks as the oldest or second oldest state in the country. So from day one of the pandemic over a year ago, concerns around equity around ages has been a concern of ours. The same applies with respect to vaccines and vaccinations. We too are working to set up a call center that will be hopefully largely populated by folks who are used to and comfortable working with senior Mainers to help them understand where to get vaccinated, how to register, when to show up, to not use confusing terminology like a QR code and things of that nature, so that folks can register without even needing an email address. They can just write down a confirmation number and a date and time. We know that's out there. I don't know if there's a national solution, or even if a national solution would be the right call, because there are so many different cultural complexions within states, but we're definitely working on setting something up. Now, that's not to suggest that there is nothing in place right now in our state. Many of the hospitals have done a great job setting up similar systems, but we are working to have a unified number for the entire state.
Thank you both. We'll probably take one or two more questions, operator.
Yes, sir. Please go ahead.
Hi, thanks for taking my question. This is Carla Johnson from the Associated Press. Two parts to my question, both having to do with chain pharmacies. Mike Fraser mentioned an allocation to long-term care pharmacy program based on beds, not census. What was the scale of that over-allocation by numbers? Are there states where that is worse or better? And then for the upcoming retail pharmacy program that is just getting started, will you in the states know where those retail pharmacies are, where doses are going exactly? Will you have some accountability through that program to keep track of where doses are going? Thank you.
Sure, I can start. Great questions, Carla. And you and I worked together back in Illinois back in the day with Melanie Arnold.
That's right.
And so, yep, good to hear your voice again. The two observations as to the former question. So with respect to the over allocation or overcommitment. I don't have a sense of how it varies state by state. We've looked at those data within Maine and have found great variation just within the state, even within certain counties. Some facilities had census rates of 50 or 60%, others were at 100%. In the aggregate, what we found was that about 75, 78%, maybe it was safer to say 75 to 80% of beds in Maine were filled. Thus, there was an over-allocation of, let's say, approximately 20% or so. We're not letting those doses go to waste. We're analyzing those, and we're going to be moving those doses back into the general population. But what we did see in working with our colleagues here was great variation across the state, even within the same geographic area. So that's kind of where we're working. As to the latter question around the moves announced this week by the administration, I don't know that there's a uniform policy. What I will say is that, at least in our state, in discussions with the partners that we have been vetting or did vet, I was very clear that I wanted to have say over which of their locations were activated first versus later on. And I was very clear in that regard that I wanted to be able to activate locations in disaffected or rural areas first and worry about areas where there was already sufficient coverage from other vaccination sites. I wanted to worry about those later. And that was one of my conditions for doing business.
And one of the things that's really important to think about the long-term care project, it's not just the amount, but the timing. We had to allocate it all up front, and it sat idle for a long, long time, right? So instead of the way that we operate on our drive-through clinics, we run the clinics based on an anticipation of delivery the next week, right? So we don't have enough vaccine sitting somewhere for a whole month, which is very different than the long-term care project. They had it pre-allocated, sitting, waiting for the whole project to be completed. So if we think about the time value that we lost there by not having it more a rolling inventory like the rest of our operations, we would have been in a lot better shape, I think, at least for Mississippi, because even now, 22% of our entire vaccine allocation has been sent for that one program.
Dr. Dobbs, I want to build on that. I agree completely. I couldn't say it as well as you did, but that's exactly right. And the problem has been exacerbated to a large degree because what was originally envisioned as maybe a multi-week, 6 or so weeks between the first clinic, second clinic, and third clinic has now become a much longer-term program, unfortunately. So that over-allocation has been stretched over a longer-term period. Again, we are starting to move doses out of that to get them into general population and circulation, but the problem is acute in that regard.
Thank you both. We've been in touch as ASTHO with the administration on the retail pharmacy program to make some of the state interests known. One of the most primary was the site selection process, which we understand is variable in terms of how the drugstore chains are working with state health departments. So as this rolls out, it's our hope that state health officials and the chain drugstore representatives for every state are going to be able to discuss site selection more strategically, but that's not guaranteed yet. I'd also state that it's our understanding that program is really right now in sort of a trial phase. That we certainly understand that the retail pharmacies are great vaccinators and have been historically, and it's going to add to capacity, but until there's a lot more vaccine, we probably shouldn't turn that on to its fullest extent possible, lest we again distribute the limited supply we have to other places. So, with that, again, this has been a great hour, and I appreciate Dr. Dobbs and Dr. Shah's expertise, and certainly the questions and all of your participation. If we didn't get to your question or you'd like to follow up on an angle that we didn't cover today, please just email media@astho.org, and one member of our team will get back to you this afternoon for sure. Thanks again to all of you. Thanks to our operator, and certainly wish everybody a great rest of the day. With that, we'll conclude our call.